then. And I would like to invite the panel faculty, Dr. Ajoy Shetty, Dr. Shardul Soman, Dr. Malcolm Pestanji, and Dr. Ajay Kothari. Please come on the dais. Thank you. First topic is by Professor Malcolm Pestanji, Art of Execution, the SI Joint Fusion. Professor Abbasi. Good morning, Professor Abbasi.
Good morning. It's an honor and privilege to be with you. Whenever you are ready, I can share my screen and I can start.
You can share your screen and start.
Okay, wonderful.
Thank you
very much.
Thank you for joining us.
Please tell me when you see my screen.
Yep, we can. Please go ahead.
Excellent. Well, I would like to talk about sacroiliac joint, and I try to stay within the limit of the presentation. But 10 years ago, I would have told you I don't see sacroiliac joint. It is one of those things that if you don't look, you never see it. But once you start including it in your differential diagnosis, it is everywhere. Now, let's start with this. These are basically well-established data. If you get 100 patients with a back pain, 22% of them are sacroiliac joint. By the way, 22% sacroiliac joint means 78% is not sacroiliac joint. So we as a spine surgeon, we are so used to attribute many of these patient symptoms to spine, and this is a good path, but you cannot dismiss that 22% that is not spine what's causing the symptom. Now, what as well is important, that after especially patient gets spinal fusion, especially L4 to S1 fusion, if patients still have symptoms, even same symptoms, 43% of them are sacroiliac joint and not spine anymore. Now, I can just tell you that since I have included that in my differential diagnosis, the rate of my Feldback syndrome is 1/4 of what it used to be. Because as we come back to that, many of the symptoms that you contribute to Feldback syndrome are neglected or disregarded sacroiliac joint problem. Now, sacroiliac joint is a very strong joint. Your whole weight or 2/3 of your weight is hanging on it. It is ligamental. It has only 4% natural motion. As a matter of fact, the only time it literally moves is when a woman is giving birth to a baby. And I'm going to tell you that any excessive motion is pathologic. Now, I'm going to just show you some pictures of the anatomy that why this joint can be approached laterally so easily. As you see, most of the neural structure and vascular structure are practically anterior ventral. So a lateral approach has been established, a good approach. We have to talk about the anatomy. This joint has two parts, the so-called ligamental part and the boomerang, the yellow part, which we call the articular part. Now, I want to show you a picture of a normal sacroiliac joint. Many of you guys are orthopedic. You know, if you see something like that in any other joint, that's a pathologic, very pathologic arthritic joint. But this is a normal sacroiliac joint. Because it doesn't have a motion, nature allows a lot of variation. I can tell you that this patient that you will see, they are younger, about 10 years younger than people with irregular spine. They are mostly female. Many of them are athletic. They are runners. They are joggers. And this is another picture of the distribution of this problem. That you see again that when you have patient with a back problem, what the distribution is. Now, I'm going to move forward that practically I see a lot of failed back syndrome from other colleagues that when you just do the basic diagnostic, you know that this is the sacroiliac joint. Symptoms are extremely similar to lower lumbar spine. So, and I think what was surprising for me is that it can pretend to be any other problem. It can pretend to be the facet, it can pretend to be the disc problem, and the symptoms are extremely similar to especially facetogenic pain. Imaging is only to rule out other pathologies, but imaging is not diagnostic of sacroiliac joint because the variation is so much. Very often misdiagnosed. And this is the pattern of radiculopathy that you can get with the sacroiliac joint. Please take a picture of that. So radiculopathic pattern of the pain does not rule out sacroiliac joint. Now, I'm not going to be very short about the diagnostic algorithm. It's obviously the clinic, the symptoms, but it comes to 2 points. And those are literally, it asks the patient put the finger where the pain is. And you see it's lower, it is more lateralized, and as well the so-called provocation test. I'm not going to go through, for lack of time, through this individual. By the way, when you ask the patient point to the where the pain is, and they are within 1 inch from the sacroiliac joint twice, that is the so-called 14 test. And then we have these various provocation tests. Please refer to one of my other talks or to my webpage to go over all these provocation tests, what they look like. But if you have 3 of those provocation tests plus 14 tests positive, you have practically 85% chance that you're dealing with the sacroiliac joint. So I'm not going to go through this test, but it comes at the end to so-called diagnostic injection. The diagnostic injection I'm going to show you, it has to be low volume, so you don't infiltrate everything. It has to be with the contrast, and it has to be confirmed with CT or X-ray. And if you have 2 or 3 injections, each of them giving the patient 75% pain, even for a few hours while numb pain is gone, then you are positive for sacroiliac joint. I'm going to just show you this picture that's extremely important. What you need to know about this, that when they randomized and after 6 months, it was unethical to continue the non-therapeutic group, and they converted them all to the therapy. And look at them, all of them, the dotted line responded the same way. It is a very effective procedure. Now, I'm going to show you some pictures that are important for identification of the sacroiliac joint. This is the lateral view, where the greater sciatic notch and the ala of the sacrum have to be aligned. That is a true lateral view. This is the so-called inlet view, where practically you are looking at the true axial view of the sacrum. And this is the so-called outlet view, practically a true AP view of the sacrum. You can imagine, because of the anatomy of the sacrum, you can get certain angle that you get the true AP and axial view of the sacrum. I have tried tremendous number of implants, and it seems all of them more or less work the same way. But I like the material screws, which are 2.5 times stronger than plugs, and something with the bigger inner cavity because it turns into actual fusion. So this is an actual surgery. What I do first, I draw the shadow of this sacrum on the skin, as you see here. Then I go from promontorium to the middle of the sciatic notch. I draw that line, and the middle of the sciatic notch is where you enter the skin. The way I do the surgery, I aim perpendicular to the sacroiliac joint. There are so-called true lateral to medial approaches, but I use true perpendicular to the sacroiliac joint approaches. And practically, the entry to the skin, as you see, is in the middle of the sciatic notch. The entry to the iliac bone is just anterior to the shadow of the sacrum. That gives you the angle that once you go through the iliac crest, you're dead center of the sacroiliac joint. Now, again, the so-called inlet view, the so-called outlet view, and it doesn't really matter what you use. It seems that this patient truly responds well to the surgery. Now, the way I use it now, I use this trident that you practically put the main screw and the side screw go through the screwdriver of the first screw. So practically you are done. After you put the first screw, you are done. In average, it takes about 15 to 20 minutes to do this surgery. And I'm just going to show you one more slide here. And this is my last slide. Colloquially, we call that joint chameleon joint because it can pretend to be many other problems. But as well, we call it miracle joint. People who have done that understand why I say that. These are the patients who have been told there's nothing wrong with them. You do a 20-minute procedure, they come and stand up and they hug you 1 month after the surgery because their symptoms are gone. But as well, I call it the so-called Cinderella joint because many failed back syndrome are neglected sacroiliac joint. It's a beautiful procedure. If you take anything out of this talk, is just include that in your sacroiliac joint and let the patient stand up and put his thumb on where the pain is. Please do that. Lay hand on the patient. That really will change your practice. Thank you very much. I really appreciate the opportunity.
Thank you. Any questions from the audience? Dr. Abbas, a very nice talk. You did mention that CT, MRI was not contributed to the diagnosis. Definitely there will be some degenerative changes. What are the points? You said the test is very important to the localizing test, the 14 test is very important. But for you, which is the most important test, the block or the clinical test with the block?
Well, about 6 years ago, the Medicare in the United States established those criteria for diagnostic. You have to have 3 provocation tests positive and 14 positive, then they allow you to do the diagnostic injections. And it used to be 3 injections that are low volume, 2 to 3 cc with contrast confirmation and literally X-ray or CT. And each of them has to give the patient 75% improvement. Just 3 years ago, Medicare reduced that 3 injection to 2 injection because the results are so impressive that we know that after 2 injections, if 75% of the pain temporarily is gone, the diagnosis is confirmed. So, but there is it is not one or another. It is a progression from clinic to provocation test to diagnostic injection. It's still the rule is that we have to get imaging because we have to rule out that there are other pathologies. But because of that, even normal sacroiliac joint is very degeneratively changed. In the CT, you see a lot of degeneratively changed SI joint that are not clinically relevant.
You did show us that the anatomy-wise, the SI joint is a horseshoe, a J-shaped joint. Therefore, when you're doing fusion, does it, the fixation includes both the component of the joint? Mm-hmm. Or is it better to put your main screw in the center?
Well, people, lots of us who do scoliosis cases, sometimes we do as well sacroiliac joint fusion to include that in our practically in different methods. We know that the ligamental part is very vascular. What that means that if you have done scoliosis cases, you go there, you start drilling there, it just bleeds and bleeds and bleeds. So I myself try to stay in as close as possible to the so-called boomerang or articular part of the joint. But at the end of the day, if you do it minimally invasively and you are not using a lots of drilling and so on, I think as long as you immobilize the joint, doesn't really matter where you go. But naturally, since I have done it open traditional way and I know how vascular that ligamental part is, I try to stay in the articular or the boomerang part of the joint.
Okay, what is your experience or comment on doing SI joint fusion in combination with the adult deformity? When you are going across from the lumbosacral fixation, there are now fusion devices which goes as the SI iliac part of the device. Do you have experience with that?
Well, when I used to do lots of open surgeries, in long construct, I tried always to use S1, S2 sacroiliac screws, the long screws. It is, I know in the last 4 years, especially through SI Bone and this company, they're trying to popularize that when you do long construct, always do sacroiliac joint. I think I like it more like a stage procedure, because I have seen that many of these patients, if you do a good construct and you put an iliac screw if you need to, you don't really need to fuse the sacroiliac joint. But I think it's nothing wrong with that. But I try, if I need to do that, I like to rather stage it, because not everybody needs that additional fusion.
Okay, thank you, Dr. Abbasi. I'm there where you were 10 years ago. Still not convinced that SI joint disc cause problem. Probably, I will probably have to be much more specifically looking for it. Anyway,
Well,
thank you for the talk, and
My
see you
pleasure.
sometime.
My pleasure.
Thank
Thank
you.
you.
Thank you, Professor Abbasi. Wonderful talk on SI joint. And we move on to the next presentation. And we have our very own Dr. Ashwin Khange, the pioneer of